predictive scores in mammography about density, bireds, and adjunct mammographic techniques that enhance detection, special breast, they've asked Paget's, then pregnancy, CAN pregnancy, inflammatory breast, then trials have not added, and metastatic I have not included, so only these two are remaining. Then what is there? Okay, and individually about ovarian ablation, suppression, fulvestrant, they've asked, case-based management of all subtypes, early and locally advanced, they have asked. Then pretty much, and screening with note on screening in India. Then this marker of basal myoepithelial have not included. Apoptotic markers anyway, but not specifically in breast I have not included. TNBC is there. Then case-based managements are there. So then molecular classification, yes. Locally advanced, yes. Breast conservation, oncoplasty is there. Stage 3, implant based in oncoplasty only it will come. Bone dosimetry I have not included. Gene expression analysis, yes. So while we go through, extra things that we have covered will be DCIS and some imaging technique and MRI have added. So where is it? Okay. So we'll go in sequential order, starting from risk factors. So what are the questions that they have asked is risk assessment, to know what's the percentage of risk in predicting incidence of cancer in lifetime and their implication on screening, chemo prevention, surveillance. So what are the risk factors? One, inherent hereditary predisposition. In that we will know high penetrance gene, low and intermediate. Hormonal factors, early menarche, age at menopause, pregnancy, number of childbirth, spacing, lactation, menstrual history, use of hormone replacement therapy, obesity, dietary, physical, ionizing environmental factors, and mammographic density and benign breast diseases. So this picture I've taken it from Devita, where relative risk less than 2 is associated with hormonal changes, that is early menarche, late menopause, nulliparity, on estrogen plus progesterone supplement, HRT, alcohol use, and postmenopausal obesity. Then proven genetic or association with genetic syndrome family, that is one, first degree relative with breast cancer, check mutation, first childbirth older than 35 years, proliferative breast disease, and dense breast. They have relative risk of 2 to 4 in risk of accumulate in risk of breast cancer in lifetime. More than 4 is associated with BRCA1 and 2, PAL-B2, LCIS, atypical hyperplasia, and radiation exposure before 30 years. In screening, they have mentioned about specifically 6 risk factors, and that I have divided into two and two. The 2 factors are associated, the ones are proven genetic mutations, proven genetic mutation, and by all these risk assessment model, if the risk is more than 1.7%, like the Gale model, if it is more than 1.7%. 2 is if they have exposure to radiation between the age of 10 to 30 years, that is one thing, and they have family history. And the other 2, there are 6 actually, the other 2 ones are, when we go through we'll see, I don't remember. Okay, so based on this, they come under increased risk of development of breast cancer. So there are 6 categories, and depending on them, screening has been adjusted accordingly. In that screening, clinical breast examination, genetic counseling, and screening by imaging modality. All of them are included, and it is different by their different risk categories. So this is one table that we have to add. And screening for MRI, just note this as to depending on your risk, and MRI recommendations are, for this category it is recommended by evidence, by expert opinion. This category, insufficient evidences are those for this, and not recommended for those who have less than 15% lifetime risk. So a BRCA mutation individual or their family member who is not tested for a BRCA mutation, and those who have a lifetime risk of 20 to 25%, they come under the category of recommendation for annual MRI. You can base on your recommendation on expert opinion for those who have received radiation at the age between 10 to 30 years. They are Lee-Fraumeni syndrome or relatives of Lee-Fraumeni. They are Cowden or uh, Ruel-Baca syndrome or their relatives. Insufficient evidence exists if they have history of LCIS, atypical hypoplasia, extremely dense breast, they have personal history of cancer, or in their lifetime risk is 15 to 20%. It is there is evidence which is insufficient to recommend MRI for them. Those who have less than 15% lifetime risk, you don't recommend MRI at all. Then this was the high, moderate, and low penetrance genes that we were speaking about. BRCA 1 and 2, P53, P10, STK, LKB1, and CDH1. They come under high penetrance. Check ATM, BRIP are moderate penetrance, and the others are low penetrance. So, about the syndromes associated, just to name them, BRCA is associated with HPOC, P53 germline and somatic. Somatic P53 is associated with most of the solid malignancy. You can name it. You can write under this. Lee-Fraumeni is associated with germline P53, and it is not as common as somatic P53. CDH1 familial diffuse gastric cancer. P10 is associated with Cowden. STK11 LKB is Peutz-Jeghers syndrome. CHEK2 mutation with Lee-Fraumeni. MLH, MSH, you can write about Mutoyer association with breast and even HNPCC. PALB2 and BRIP with Fanconi anemia. All of this have autosomal dominant pattern. Then coming to screening. I will just tell you in brief. Where is that? I've written that. Just a second. We'll have to know the screening, that is the age of screening, modality of screening, and their adaptation for Indian scenario, high risk screening, and evidence for actually this is clinical breast examination evidence in India. So NCCN recommends starting age at 40 and you stop at 74 years, and it is recommended annually, and mammo is the one that is recommendation. Here when you write mammo, there are two things. Screen film mammography is one thing, and digital mammo is another thing. Most of the evidences are for screen film mammography, and only CISNET, this trial is for digital mammography. So here it is a single film taken in two different views. So for your screening, there is self breast examination, there is clinical breast examination, and there is imaging. For all your trials, mammography is the one that has been compared, and that has evidences. So there are mention of 1, 2, 3, 4, 5, 6 trials. I mentioned 6 trials. More or less, all of them have included 40 to 74 years. And in the descending order of their decrease in mortality. So the benefit they found was there was mortality decrease with early detection as low as 20% to as high as 30%. Especially this difference was made out when there was increase in age more than 50 years. The gray zone was that 40 to 50 years. Here we were worried because here there was no significant influence in the mortality rate. You are unnecessarily exposing this young population for radiation frequently. So that is why the US Star Task Force adapted 50 years as their cutoff, but their recent draft, which is mentioned in NCC, and says that they have brought it down to 45, encouraging their starting age at 45, and between 40 to 45 they say it is patients and your physician shared decision making to instigate them to start their mammography. So for NCC you will write 40 to 74 years. Then all of these studies took as early as 40 and ended their study till 74. They have group categorized, dividing them by decades, 10 years, and saw who got maximum benefit. So the points that you'll have to write is just mention these trial and tell that they showed some mortality decrease by increasing detection rate. By quoting Canadian could show some significant increase in the detection rate, even though these showed a mortality decrease in the range of 20 to 30, they were not statistically significant. One, all of them use screen film mammography. This CISNET is the trial that used digital mammography as their screening modality. Then coming to various other agencies that recommend screening. So I have mentioned we will just see only US Preventive Task Force and American Cancer Society. So the task force starts at
6 trials कौन से बोल रहे हो?
This sixth trial is to see if mammography used routinely in screening will have some benefit. So that is this one: Swedish,
Canadian, UK, and
Canadian, UK, and Malmo mammography, and Gothenburg.
5.
Gothenburg.
And CISNET 6. CISNET 6.
And the 6 is CISNET. So just mention them by names, because each of the thing I don't think we'll be remembering at the end. So as low as 20%. Tell me.
नहीं okay ठीक है. 6 trials that suggested mammo as a screening modality.
Yes, where there was increases detection rate and
film mammo, screening film mammo as a screening modality, और CISNET ने बोला कि digital mammography use करनी है.
Yeah, they use digital mammography in there. But when we go through the NCCN is recommending digital mammography with tomosynthesis, because even in low resource or middle resource country like us, they have access to this. So they've included in their screening. Digital mammography with tomosynthesis. What is the advantages? Your callbacks are decreased. So when you take screen films, because of their false positivity or inconclusive, you call them back and you rescreen them. That rate decrease with adding tomosynthesis to your digital, your mammography, screening mammography.
उसका कॉल बैक समझा क्या होता है? मैंने अपने रेडियोलॉजिस्ट को फ़ोन करके पूछा था. ये डिजिटल मैमोग्राफी या कोई फिल्म लेते हैं ना, तो वो फिल्म जो रहती है वो शायद स्टोर नहीं होती, तो हमको पेशेंट को दोबारा बुला के फिर से करना पड़ता है टेस्ट. तो और ये वाला जो रहता है ये सेव हो जाता है, तो आपको एक ही फिल्म को 4 बार खोल के देख के पढ़ सकते हो, ऐसा है ना? ये मेरे को कॉन्सेप्ट समझा.
Because of that exposure and delineation resolution, you will not be able to report it properly. So you will have to, call the patient again, subject them for a proper exposure and filming and all that. In that, they said better you take a digital mammogram, add that 3D multiple slices like tomosynthesis, so that you get a better delineated mass against parenchyma, especially in dense breast. So if there is question on tomosynthesis also, I've added that. I'll take. So when you're mentioning, just mention about the other agency, what is their recommendation. US Preventive Service Task Force, they started their screening at 50 and ended at 74. They found that screening beyond this really did not have any benefit. Here, this is not an annual screening, it is biennial screening where 2 yearly once you will screen them. And American Cancer Society also started at 50 and they continued till 75 years. So these two things you can just add. Then what I wanted to tell is this. In Indian scenario, what you'll have to mention is, we've because of the resource, increase burden, decrease resource, we follow something called opportunistic screening. Where when and wherever you can get to meet a patient whom you consider as average risk, you will subject them for clinical breast examination 2 yearly. And by the study published by TMH, where the study was conducted for 1,51,538 patients at Mumbai Mitra et al., they said that clinical breast examination conducted every 2 yearly by primary healthcare workers significantly downstage. So you could pick up the tumors earlier in their stage, and that is about 15%, and they translated in decrease in mortality about 30%, especially in those who are aged more than 50 years. So these 2.1 opportunistic screening, and 2 is this Mumbai Mitra et al. That is with clinical breast examination. So in Indian scenario, that is what it is. Mammography is very resource intensive, so you will have constraints. So they found that this was equivalent to mammography, where there was not much of difference when compared. This study showed that on par with your mammography, this still can also detect early stage tumors with decrease in mortality. So in Indian scenario, this is one of the evidences that they have published. Then going back to our
हाई रिस्क स्क्रीनिंग का तुमने अभी तक नहीं मेंशन किया.
That I'll go next. In that, this one only does that. So now coming to high risk. This is with okay, that 6 things I was telling. No, I'll also see that off. Just a second. So I've gone through this NCCN and I've made notes which I've incorporated in that only. So here, see, NCCN says there are. This is average risk. This is increased. 1, 2, 3, 4, 5, 6. Okay, not these 6. Just a second. Those who have lifetime risk of more than 20%, which is assessed by these risk models. That is 1. Those who have been exposed to prior thoracic radiation between 10 to 30 years. That is 2. And those with more than 35 years of age, with their 5-year risk of invasive breast cancer being more than 1.7%. Those with having more than 20% risk based on their history of atypical ductal hyperplasia or lobular hyperplasia or carcinoma in situ. So these they have taken as risk groups for screening. So each one of them they have separately given in templates as to do what. So I will just summarize as to what they finally wanted to tell. So these were the 6 categories. So when you meet one person, she will either be average or she will be a part of this increased risk, which will come under all the 6 categories. After defining their risk, if they come under average risk, imaging criteria we have already discussed. So you will add a note on breast awareness to them, their clinical breast examination, their imaging by mammography with tomosynthesis, and supplementary test that you will use will be contrast enhanced mammography, molecular breast imaging, and ultrasound. uh, Tomosynthesis is already given. So these are some of the adjuncts that will increase in your detection rate, better delineation of the masses against the parenchyma. So in individual these risk categories, meaning what you'll have to remember is those will come in more than or equal to 20% risk. How do we know this? This 20% risk can be because they've been detected with atypical ductal hyperplasia or carcinoma in situ, or any of your risk assessment model said so. They had a history of radiation between 10 to 30 years, or they've been a proven genetic a proven genetic mutation patient or a survivor. Then so that's it. So if they all come under increased risk, what you will have to do? There are some age cutoffs that are extra from this average group. That is, 25, 30, 35, 40. Less than 25 years, irrespective, you will not do any radiation based imaging like mammography. For example, there is a patient who is increased risk by the virtue that she is a daughter of a BRCA mutated person who has died at probably, say, 32 years. So, by criteria, they said 10 years before the onset. So, it would have been 22 years. Here, you will not subject them for any radiation associated testing. So, you will start with MRI only after 25 years. One. Then, at what is the significance at 30 years? For example, clinical breast examination you were doing, you found a mass. Then, a breast lump for less than 30 years, no radiation based imaging.
USG.
You will do an ultrasound. More than 30 years, yes, you can do mammography, especially when there is high clinical suspicion index. And for 35, this is 30.
वो गेल मॉडल
35
मोर
there's
देन
nothing.
35 है ना?
Correct. For more than 35 years person, if you apply Gale model and it says they have more than 1.7% risk, so they become increased risk category.
और 40
So other
years से
than
कम
that,
की
there is no
screening शुरू करें.
special imaging change that we have. 40 years, they regularly come in your average risk, and you can do. One more thing I had, with this MRI, you will do complementary mammography for screening each time,
It's
or
complimentary
alternate?
नहीं है. That's like मैमोग्राफी तो करनी है, उसके साथ MRI is extra.
No, in those
तो उसमें ना एक
we
तरीका
have,
मिला था कि लोगों को क्या बोला कि 6 मंथ मैमोग्राफी और 6 मंथली MRI, तो वो साल भर में 2 बार 2 तरीके से चेक हो जाएगा.
okay.
तो मतलब दोनों को
So
एक ही टाइम पे कराने से बेटर है कि उसको बोलो कि 6 मंथ MRI करा है, उसके बाद 6 मंथ मैमो करा है, फिर उसके 6 मंथ बाद MRI करा है, फिर 6 मंथ मैमो करा है. तो ऐसा हम लोग एनुअल करा भी लेंगे और पेशेंट.
So not at the same time, but in same year you will have both.
हाँ.
You have baseline both. Okay.
ये मॉलिक्यूलर ब्रेस्ट इमेजिंग पे क्वेश्चन आया है क्या?
It is not, but here everywhere they have mentioned use adjuncts here.
तो आ सकता है भाई.
आ सकता है ना, ठीक है. मैं एक आर्टिकल शेयर किया था, मैंने जस्ट देखा. I'm just going through क्योंकि it's coming again and again और मैंने क्वेश्चन देखा नहीं है.
That's what. This I made notes also. These two are like potential questions only. This contrast enhanced mammography also is not come, but it can come. Even molecular breast imaging, nothing. What they use is this increased tumor activity and increased angiogenesis and supply. They use technetium 99, which will be taken up by this, and that activity will be shown under gamma camera. Like how we use for Sentinel, no? Same thing.
I don't know if it comes under molecular or not, but I read of this, it also can tell you about the ER positivity of a tumor and how it is getting affected by the NACP that you give. So I read it somewhere that we also do modifications of PET, which can tell you about the ER receptivity of the tumor. So if somebody is on neoadjuvant hormonal therapy and you do that kind of PET which tells you about ER positivity, and then the uptake of that ER decreases, so that way you can also assess the response to the neoadjuvant hormonal therapy. I'll share the paper with you. I don't know if it comes in molecular imaging or not, but I think we can write it.
Yeah. Anything that uses this functional aspect of the tumor in imaging
और
is
इसमें कुछ
molecular.
रेडिएशन का पॉइंट भी था कि रेडिएशन मान लो अभी दिया हुआ है, तो उस रेडिएशन के हमको 10 साल बाद से स्क्रीनिंग शुरू करना है कि 8 साल बाद से कुछ स्क्रीनिंग शुरू करना है, ऐसा एक पॉइंट भी था. 8 years.
8 years after.
ठीक है. तो
8
अगर
years after.
हाँ, तो अगर वो पेशेंट 10 साल का था और 8 ईयर्स आफ्टर आरटी वो 18 साल का हो गया, तो 18 साल से नहीं शुरू करेंगे। लेस देन 25 ईयर्स में हमको सिर्फ एनुअल क्लिनिकल एनकाउंटर करना है और ब्रेस्ट अवेयरनेस प्रोवाइड करना है।
So in all our screening, these two we have to add. This breast awareness, genetic counseling, all of that. If it is increased risk for average people, it is you will start with breast. You will teach them breast self-examination. You will do clinical breast examination, and you will tell them annually you have to get your mammography.
कुछ याद आ रहा है, I'm happy.
So. Okay, we'll get back to that flow. In between, I'll just be breaking and we'll refer to whatever resources I've taken it from. Okay,
तो
those with
फिनिश MRI भी ना, इसी के साथ ही MRI भी फिनिश कर देना, तो सब हो जाएगा, फिर अपन डायरेक्ट मैनेजमेंट में आ सकते हैं.
Where is my phone? Just a second. I have to
हाई रिस्क कवर कर लो, हाई रिस्क पे आई गई तो.
So here, what are the indications for genetic counseling, genetic testing for? Okay, this is one personal history. Okay, for BRCA testing or the gene panel. So one, those who are less than 50 years were diagnosed with breast cancer, in them you will do BRCA testing. Second, any age, those who are on treatment, where your treatment decision is based on your BRCA status. That is when you have to start them on PARP inhibitors like olaparib for hormone positive, HER2 negative, high risk category. Then their pathology, they are triple negative. They have multiple primary breast cancer. It can be synchronous or metachronous. Those who have lobular with personal or family history of diffuse gastric cancer, all male breast cancer, and those who belongs to Ashkenazi Jewish, that racial trait. You have to subject them for BRCA. So any age with family history of one or more than one blood relative with early diagnosis of breast cancer, that is less than 50 years, male breast cancer, ovarian cancer, pancreatic, prostate, which is metastatic, high or very high group risk group, more than or equal to 3 diagnosed with breast and prostate of any grade. So if they have prostate, either they should be metastatic or they should belong to high or very high risk. If it is multiple members, like more than or equal to 3, any form of prostate with breast cancer can be taken into account for your genetic testing. The criteria for test may be considered in those who have personal history less than 65 years, not meeting the above criteria. Personal history of breast cancer diagnosed at any age, who have close blood relative, one or more of them, with prostate cancer. The other ones are those who have individuals who have a probability by models like Tyrer-Krusek, that there is risk of 2.5 to 5% probability of BRCA being positive, and personal history of malignant phyllodes. Those who have low probability of these high penetrance genes, that is less than 2.5%, there we don't here the chances that you will get BRCA is less than 2.5%. So those are females diagnosed with breast cancer more than 65, but they don't have any family history of these things, and those diagnosed with localized prostate with a very low risk score with no family history. In them you can omit doing BRCA. So BRCA 17Q21, 13Q something, lifetime cumulative risk of breast is 60 to 80%, and BRCA 2 actually is not so much, but it will come close to around 65. Ovarian 20 to 45%. Ovarian in BRCA 2 is 10 to 20%. So what are the associated cancer with BRCA 1 will be fallopian, pancreatic, prostate, uterine, cervical, colon, testicular bone. So all these gynec, colorectal, and urogenital. In BRCA2, special mention is about male breast cancer here with GB, HPB, and upper is included, stomach, GB, bile duct, malignant melanoma. So 2 M's, melanoma and male breast are added here. So by grade and histology here, BRCA1 usually is associated with TNBCs. They are high grade with high proliferative index. Comparatively, BRCA usually will be later onset. They are mostly ER positive with less likely to overexpress HER2. They are also high grade. So MRI will finish now, but I've not imported that. Give me a minute.
You continue with your flow if you have not added. No.
These individual risk factors they have discussed in detail, that we will not worry. We'll just leave it.
ये तुम्हारे स्लाइड्स में है ना? ये वो प्रेजेंटेशन आपने शेयर किया उसमें है ना?
हाँ
है ना? ठीक, मुझे ऐसा लग रहा है
रिमेम्बर
करने का मोटिव ही यही है कि एग्जाम के लास्ट दिन बस वो जो मैराथन जनरल ऑंको, मैराथन सिस्टमिक ऑंको को खत्म कर लेंगे बस, और एग्जाम दे आएंगे भगवान का नाम लेके.
We'll finish up this. Whatever is assessment model 1, when they give you risk assessment model, I think we can write in both. Even predictive models also we can include that, molecular oncotype DX for invasive and DCIS and all that, endopredict and all. These are also predictive of recurrence of risk models that also we can add in our answer. Here, these are lifetime risk assessment of breast cancer probability in a woman. So each of these have different cutoffs. So they'll estimate risk for over next 5 years, up to 90 years in Gale model. Don't go into the details of it, but generally to tell that some estimate till what next 10 years, what is the risk of getting breast cancer. So there are different models, that is Gale, Claus, Tyrer-Krusek, BRCA Pro, and Bodacier and BCS. What is important is what they include. What by history, what all are included, whether they include your genetic testing in risk assessment, is your family history taken into consideration while you assess the risk. So the drawbacks of one is taken over, is compensated in others. For example, if you take Gale model, which was the oldest and the first to develop, they took more prominence for personal history, their biopsies, age, and all hormonal factors, and they omitted a history of DCIS in personal history. Family history was they've written not taken, but it was there. Family history of first degree, yeah, it was there, but BRCA, which is the driver thing, was not used in this Gale model. This score actually is 1.77 for all purposes of screening. To tell high risk, it should be more than 1.7%. So what is the utility? 1, you will know whether they come into average risk or high risk. 2, what do you want to incorporate so that you will detect early and reduce their mortality? You will give them genetic counseling. And do you resort to some form of preventive therapy like chemo prevention, risk reducing surgeries? Yes, once you categorize them, you will start their screening early. You will subject them for genetic counseling. If they have not been tested for BRCA, for example in Gale model, you will ask them to undergo genetic testing, and you can start them on tamoxifen for chemo prevention. So what are the components? Age of that person, age at menarche, first live birth, previous breast biopsy. In that, only atypical hypoplasia is taken into consideration. Family history, how first degree, second degree relatives with breast cancer has been taken, and it's a computerized model where it will give you a score. Then coming to Tyrer-Krusek model, here what is extra? LCIS that was not taken has been added here, and history of hormone replacement therapy is something extra here. So all these ticks and no, now it is not there. Here it's all tick for everything actually. Even MRI, you can take it for consideration in your screening modality. Then with the models that use BRCA 102, 1 and 2 or 102 in their models are Bodacier and BRCA Pro. In Bodacier, they have taken even ovarian and male cancer, breast cancer history. Then in BRCA Pro, along with breast, male, bilateral, and BRCA status has been included. So basically, you mention about them, mention the flaws in them, and then how are they useful in your screening and chemo prevention. This we read. Okay, the risk reducing strategies are enhanced surveillance, that is, you'll call them for 6 or 12 monthly clinical breast examination, behavior or lifestyle changes, chemo prevention, risk reducing surgery has to be offered, and genetic counseling. Then coming to in risk reducing chemo prevention, it is by tamoxifen or raloxifene, examestane, 20 mg per day for 5 years is recommended. It's the thing here is that this should be used in those who have increased risk by Gale model or they are aged more than 35 years. So this had agonistic action on uterus. That has been that is why this is uterine safe. You won't get hypoplasia, dysfunctional bleeding, and increased risk for endometrial cancers in raloxifene. Then bilateral salpingo-oophorectomy. Once the patient is completed her family, especially those who are breast cancer survivors or on treatment, you have to encourage them to undergo bilateral salpingo-oophorectomy. There are some guidelines that are indicated in bilateral salpingo-oophorectomy by NCCN. So those BRCA mutated patients, you have to take peritoneal lavage. You have to include the fallopian tube as closest to the cornual end. This has to be sectioned according to the CFIM ultra staging protocol by the pathologist. Here, even if it comes as thick in the specimen, then you'll have to complete THBSO in them because they will have high risk of conversion into invasive carcinoma because it's a precursor lesion. So these are some of the points for BSO that you'll have to add. So what is that age adjusted BSO when you choose to do? If it is BRCA1, it's earlier. As soon as the family is completed 35 to 40 years, you should offer. In BRCA2, you can be a decade late or 5 years late. 40 to 45 is the recommended age when you have to do. You also have to offer them bilateral mastectomy as a prophylactic risk reducing surgery. Then let's come to DCIS. DCIS also I will teach you in this one only, just a second. Yeah, here. Okay, this template you have to remember. What is DCIS? There were cells in the breast duct that got transformed into malignancy, but they never breached the basement membrane. So that is ductal carcinoma in situ. So why we should be worried about ductal carcinoma in situ? Because 20 to 25% of them have a chance to get converted into invasive malignancy, but it will take a long time. It won't happen in a year. It might take as small as 5 years to as long as 10-15 years to evolve into invasive malignancy, and that is why they say that you need not be very aggressive with them. Second thing, DCIs are known to have ipsilateral breast tumor recurrences rate, which is quite high. And why don't you just resort to surveillance? Because there are high chances that these DCIs progress to invasive malignancy. So, by definition, these are malignant cells confined to basement membrane and not beyond. So, the risk factors are just like your invasive breast carcinoma, it has hereditary predisposition, family history, anything that increases estrogen exposure like nulliparity, later onset of pregnancy, that is unopposed estrogen action, dense breast, they're obese, they're alcoholics and tobacco users. Increased breastfeeding is protective. There are two ways this can present because there is increase in incidence of screening mammography. They can be screen detected, non palpable, or they can present as palpable mass, discharge per nipple, breast asymmetry, or pegetoid or Paget's disease per se. So, what you will do, you will take a thorough history for their family history, then do their physical examination. You will get a diagnostic bilateral mammogram. What's the picture that you will pick up? You have to first see how the parenchyma of the breast looks and if there is any focal asymmetry in the breast mammography that you see. And you have to characterize microcalcification, which is characteristic for DCIs. Excuse me. So what are the different types of calcification that you can come across here is it can be punctate linear, or it can be branching, or it can be very amorphous, scattered, and pleomorphic. Here there is special mention about determination of ER status because most of them are ER driven. Not that HER2 cannot be found in them, but the incidence is very less, and targeting HER2 has not been very effective in treating DCIS. All of them you will subject them for genetic counseling. In case there's a family history which is strong and they come in increased risk category, then MRI is indicated. Then what is the way to go about this? Something about pathology. Here they can be comedo type or non-comedo type. Basically, when you cut across through that mass forming DCIs, there'll be areas of necrosis indicating they are having high proliferation rate. So there's comedo, which is a bad aggressive type. Non-comedo or cribriform solid micropapillary or papillary by pathology. So now here you will address the primary. You will prophylactically stage the axilla if need be. Then you will add some form of adjuvant, RT or endocrine therapy or both. So how do we decide as to what to do when? So now you did a mammograph, you found DCIS was associated with a focal asymmetry, maybe a non-palpable lesion, whatever. You did biopsy, you found out there can be three types. It can be pure DCIS, you found no invasive component. You can have a micro-invasive DCIS where the invasion is less than 1 mm. Still the management remains like DCIS only because its prognosis is very much like pure DCIS. Next, you can find a frank invasion. When there is a frank invasion in milieu of DCIS, you will manage them like invasive malignancy. So NCCN recommends no routine SLNB except for two scenarios. If you're subjecting the patient for mastectomy because there is extensive DCIS where you find parenchyma preserving is not possible. Second, when there is mass forming DCIS where the component of invasion not picked up in biopsy which might come positive in histopathology is very high. Meaning if it is forming mass,
when it is in upper outer quadrant. When you are doing lumpectomy in upper outer quadrant, then also sentinel lymph node biopsy is indicated.
Okay, but you can repeat it later, no?
उसमें रीजन उसने ये दिया है because you will be disrupting उधर का lymphatic channel because of operation. When you are operating upper outer quadrant na, so you are disrupting lymphatic channels of the axilla. So in that case, you should address axilla sentinel lymph node biopsy if you are addressing upper outer quadrant for DCIS, because you are very near to that area only, na.
Correct. But in the recommendation, I did not find that anywhere. Probably it's a clinical, very practical thing.
I have read somewhere, I don't know where. बट ये भी एक इंडिकेशन था कि DCIS में कहाँ पे एक्सिला एड्रेस करना है.
In NCCN, तो what they've written is It is not indicated except in these two scenarios, where you're subjecting the patient for mastectomy and there is mass forming where there is high index of invasive carcinoma. Then they devised a Van Nyhuys prognostic index to categorize these patients depending on the risk of recurrence into low, intermediate, and high. So this is the thing. So they took age, size of the DCIS, margins, grade, and necrosis. So they gave score 1 to 3, and that was final score was 3 to 9. Depending, it's 12. Okay, because the old one did not have age. The new one added, the modified one had, they added age to it, so it became 12. So there 4 to 12. If it is low score, you can omit RT. If it is intermediate, you will give RT. If they are high risk, better to do mastectomy. This is what it says. So by age, you will divide them into less than 60 years and less than 40. In between is 40 to 60. By size, 1.5 centimeter, more than 4 centimeter. Margins, whether it is less than 1 mm or more than 1 centimeter. Grade and necrosis, if it is with the necrosis or without, depending on low, intermediate, or high grade. Okay, so this basically they wanted to omit RT. Whether you are doing an overkill for something as small as DCIs was their concern. So according to the SSO, ASTRO, and ASCO, more than 2 mm is an adequate or optimal margin that has to be obtained for DCIS. So NACBP 17 that gave to a standard that BCS with RT was equivalent to mastectomy, and in their inclusive group they had even DCIS. So you can quote NACBP 17 here. SLNB, we saw the indications, and now you will follow it with tamoxifen depending on ER status. So you will subject them for ER by IHC. If it comes positive, then you'll have to give 5 years of tamoxifen, 20 mg OD, and this is according to NACBP 4 trial, where it decreased the risk of low current recurrence when compared to placebo. So some of the de-escalation trials you can just mention Comet, Lord, and Loris. These are the 3 trials. That is Van Nyhuys prognostic index. So after in radiation also, because we are de-escalating, there is role for using ABPI if you have achieved margin more than 3 mm, and by size if they are less than 2.5 centimeter, I think. When we come for post-mastectomy radiation indications, I will tell for invasive what is the indication, for DCIS also what is the indication. So I think I have written here 2 mm margin, more than 2 mm margin you have given, and they are less than 2.5 centimeter, then you can use accelerated partial breast irradiation. Here you can finish off their radiation course in a week or two by giving only in a specified area radiation. So there is a role for ABPI and DCIS. So broadly what you have to remember, it's an in situ carcinoma. What are the risk factors? It is similar to the invasive. It can be mass forming or screen detected. Mass forming has an increased incidence of having invasive component in them. Then there is role for MRI also in this. Then you have to write about then what is the treatment. You will resort to either BCS or mastectomy depending on how extensive the DCIS is. If it is mastectomy, and then surely you will do SLNB. The other M is mass forming DCIS. SLNB is mandatory. Then following this, you can just do wide local excision in low risk group. How do you assess the risk group? By 4 factors. You will take their age into consideration. You will take the size of the lesion, the grade and necrosis, and the margin that you give. Following which you will see whether to omit radiations. In low risk, yes, you can omit. In intermediate, you will have to give RT. In high risk, mastectomy is indicated over wide local excision with radiation. Then there is role for adjuvant tamoxifen as told by NACBP trial. And this is about DCIS. So So then you have done biopsy, then you have done grading. So Nottingham grading system, you will base it on TNM, tubule
NSBP
formation,
कौन सा
nuclear
बोला?
pleomorphism, and mitotic rate.
NSBP कौन सा
Then
बोला?
coming to 24. 17 is for BCS, like our invasive only. BCS had BCT was comparable to mastectomy, and that was NACBP 17. NACBP 24 is tamoxifen.
Okay.
Okay. Then coming to molecular classification. So this table we can put. There are 7 things that you'll have to mention by while putting this table. So there are 4 groups: luminal A, luminal B, HER2 rich, and basal-like. There is question on basal-like. What are the subtypes? What are the molecular markers? I have not read. This I'll make a note, and tomorrow probably I'll write. Basal-like. Okay. So first you will start with ER, PR. Second will be HER2. Third will be Ki67. Follow it up with grade. These are something that you will get in your pathology report. Then you will write the DNA, go to molecular level like DNA, mRNA. Then P53 mutation you will add. So you basically know what's luminal A, B, HER2 and basal-like. So luminal A and B are differentiated by Ki67 less or more than 14%. So luminal A can be hormone positive or negative. Sorry, positive with HER2 new plus or minus with Ki67 more than 14%. So you finished 1, 2, 3. Okay. Then coming to fourth. The low grade one is luminal A. Rest are intermediate to high. So when you write basal-like, you can write only high. Then coming to fifth one, your fourth. Okay, fifth one is copy number. Luminal A is diploid, rest everything is aneuploid. Then sixth is microRNA expression. Here it will indicate their proliferation rate. Low proliferation is luminal A, rest everything is high proliferation. So low proliferation with good prognostic factor like high ER. In luminal B, it is low ER with high proliferation, and HER2 no, it's high HER2 with high proliferation, and in basal-like it's basal signature. Then coming to P53, it is common only in very poor types like HER2 and basal-like. So when you write this table, you will write 7 points and fill the spaces. Then coming to staging, what we'll have to remember in breast, it was both clinical and prognostic factors that got incorporated. And what are the definition for more than 10 nodes? So why these two are important? These come in the indications for post-mastectomy radiation and even in clinical trials to give adjuvant endocrine therapy. These are like some of the consideration. If you don't have multiple adverse factors, so these won't be individual adverse factors, but they'll be cumulative. If this is found and there is another high risk factor, then you will try to intensify your treatment. So that is why you should know PN1 and N2. So that is something I wanted to tell. Next is okay. Coming to stage directed breast cancer treatment. So what? Let us first define our staging. Where is it? Yeah. So in situ carcinoma is stage 0. So in stage 1, it is T1, T2. It is T1, T2, and up till N1 is included. The stage 2B is the gray area where it includes 2 subsets, that is T3N0M0, which is called large operable breast cancer. T2N1M0, even though it is stage 2B, you will resort to give neoadjuvant therapy because of node positivity, even though it is upfront operable. So this gray area, this sometimes can be included in early or locally advanced. So your stage 3 is pretty much N2s in stage 3A, T4s in stage 3B, C in all N3s are stage 3C. M1 is metastatic stage 4. So what are the stages which are included? Early it is N0 up till T3. Up till T2 you take if it is N1 plus. This large operable and T2N1 is the gray area, that is stage 2B, which can be included in either early or locally advanced. So locally advanced is constituted by operable, inoperable and inflammatory breast cancer. T3N0 is large operable LABC. All that stage 3 ABC that I spoke to you about, N2, T4 and N3 are inoperable LABCs. I would rather say where neoadjuvant therapy is indicated, is a must. So they are not upfront operable. Then T4D, it is inflammatory, where you will never put your knife before giving neoadjuvant therapy for inflammatory breast cancer. Then coming to metastatic for any M+. Another point is prognostic.
इन्फ्लामेटरी अगर प्रूव हो गया है तो इफ कितना भी अच्छा रिस्पॉन्स हो, वी शुड नॉट डू BCS. एब्सोल्यूट कॉन्ट्राइंडिकेशन है.
Yeah, correct. So prognostic, you will include your ERPR, where it will downstage if it is positive, making it in a better prognostic group. Then, okay, breast cancer and pregnancy. How do you define breast cancer and pregnancy? Detection of breast cancer during pregnancy or within 1 year of postpartum. So this is the definition. Okay. This is the definition is during pregnancy or within 1 year of postpartum. Then how do they behave pathologically? They are mostly HER2 positive and less likely ERPR positive. They are usually high grade and they are IDCs, aggressive ductal carcinomas. There is no difference in overall survival per stage, just that they are diagnosed late and there are some treatment constraints, but otherwise pretty much their prognosis is the same. You will do clinical examination. Here it is difficult to pick up masses because it will be an engorged breast and the parenchyma usually here will be dense. Imaging here, if you shield the abdomen, you can take mammography. Ultrasound is the modality of choice. MRI is advocated, but due to you can't put the pregnant patients due to habitus in prone position, then you might not be able to do MRI, but it is indicated. Then biopsy and histopathology is just like non-pregnant women, the same way. Here, radiation associated imagings are contraindicated. Next, how do you plan your treatment? This is based on the trimester of presentation. Next thing is the management is similar to your non-pregnant state, but with SLNB, there are mixed results for methylene blue sensitivity. That is one thing that we have to bear in mind. Otherwise, radiocolloid is indicated and even methylene blue can be given. But if you think, because there are no proven result, proven thing that it is harmful or there is increased sensitivity, but you can use them. Now, first, after you finished your imaging, then you know which trimester they belong to. There, let us talk about first trimester. Here, you have to discuss with the patient regarding termination of pregnancy. In case this is not their first child, or this is their second or the third, and they are willing to give priority for this treatment, because in first trimester till they complete their pregnancy, you cannot give RT. And chemo also will be started after finishing first trimester. And here there is clear indication for abortion, medical termination of pregnancy. So that is the first thing that you will discuss with the patient. Next, you will resort for mastectomy because you cannot give
one
RT
option is
till
also there if BCS ke wala if you are doing mastectomy and axillary staging, if in case post mastectomy RT is not indicated only, what you say?
I, no, that is why in first trimester you won't give BCS at all. It's mastectomy only.
मतलब there are chances कि if post of setting में if she has not achieved the criteria of post PMRT, then baby can be preserved.
See, this is their personal decision. If they think, they are worried about this and not, this is not your decision.
एक्चुअली हमारे यहाँ ऐसे एक केस आया, एक हमारे यहाँ ऐसे ही केस आया, हम लोगों ने उसका अबॉर्शन करवा दिया और फिर उसका BCS प्लस ये किया सेंटिनल लिम्फ नोड बायोप्सी, एंड फाइनल हिस्टोपैथ में वो आया ही नहीं इन्वेजिव कार्सिनोमा, वो DCIS आ गया.
Oh shit.
तो
how old was she?
She was बल्कि उसका फर्स्ट चाइल्ड था, 25 और 29 ईयर की थी वो.
We operated on 2, one in first and second trimester, but we continued. Only thing is you have to take risk for abortion during general anesthesia and all that. That's all. Otherwise, we continued the pregnancy for it.
but only it's like a safer option क्योंकि वो final histopath every time, because उसका nodule was only 1 centimeter around, तो it was like कि उसका abortion भी हो गया और उसको कैंसर भी नहीं था, उसका दोनों तरफ से लॉस हो गया. अभी वो सेकेंड टाइम प्रेग्नेंट होगा तो
बायोप्सी वाज पॉजिटिव.
हाँ, उसने बोला इन्वेजिव बायोप्सी सजेस्टिव ऑफ इन्वेजिव कैंसर, और नीचे एक छोटा सा लाइन लिख दिया कोरिलेट क्लिनिकली.
ये तो हो सकता है कि वो DCIS के अंदर छोटा फोकस था, पूरा फोकस बायोप्सी में निकल गया, तो आप उसे मैनेज, मतलब हमारे में भी ऐसे आए थे, तो उसको हमने इन्वेजिव ही माना कि वो DCIS है. DCIS में जो इन्वेजिव का फोकस था वो उतना ही था जितना बायोप्सी में निकल गया. तो जैसे अगर आपका 2 mm है या फिर 3 mm था, टोटल बायोप्सी वॉल्यूम जितना था, तो जितना बायोप्सी वॉल्यूम था उतना उसका इन्वेजिव कंपोनेंट है, बाकी सारा DCIS है. तो आप उसको मैनेज करोगे T1 whatever it is, T1B T1C की तरह, बट अगर बायोप्सी में इन्वेजिव आया है और बाकी DCIS है तो इन्वेजिव कंपोनेंट आप लोगे उसको.
पता नहीं, हम लोग क्या तो बहुत बवाल मचा, पैथोलॉजिस्ट को बहुत परेशान किया हमारे यहाँ. पैथोलॉजिस्ट की जान निकाल दी क्योंकि वो मेडिको लीगल हो गया ना, उसने अबॉर्शन करवा दिया हमने उसका. तो
ना तो हमारे में भी ऐसा एक आया था, पर वही है कि आपने बायोप्सी रिव्यू करवाया, हमारा पैथोलॉजिस्ट तो डैम श्योर था, तो फिर यही है, उसको यही बोला था कि आपका ट्यूमर बहुत छोटा था, इट वाज इन द DCIS का कंपोनेंट में एक छोटा इन्वेजिव कंपोनेंट था, तो उसको CA ब्रेस्ट T1B की तरह ट्रीट किया गया with no adjuvant therapy and everything needed, but उसको radiation
focal invasive they usually treat it like DCIS only, only if it is frank invasion with more than 1 mm and all.
If you read the guidelines by ECS, it says कि अगर आपके margins will be determined by DCIS. That is true. अगर if there is a small micro invasive component, you will take the margins as 2 mm, but you will treat it as an invasive only. आपका invasive का focus is what the biopsy has been taken out, but you cannot ignore the invasive component.
No,
we are thanking ourselves कि हमने उसका mastectomy नहीं किया.
This will be invasive because they have given invasive only. It will be invasive only if you have taken the whole specimen and there is only focal invasive, then you can be this one. But if it is invasive component,
final specimen, no invasion was there, and It was tumor board's decision, so we were safe. But tumor board हमने कहा ना, जब भी सर्जिकल पेशेंट हमारे यहाँ
कहीं से कम आती है, इवन देन आपको रिवाइज करने की जरूरत पड़ेगा। वो 5 पॉइंट पे वो अच्छे थे और पूछते भी हैं बार बार।
Okay.
No, in DCIS, it can be pure DCIS, but if it is invasive component, then it is treated like invasive only. Only in micro-invasive, I think it is treated like DCIS for margin.
अरे सिंपल सा, अभी तो मैसेज में डील कही थी उन्होंने, वो बोला है कि यार अबॉर्शन करवाना है बट सिर्फ डिस्कस ही करो, अबॉर्शन फाइनल हिस्टोपैथ करवाए आने के बाद कराओ। ये मैं जस्ट इस पॉइंट में बोल रही थी, डिस्कस कर लो कि अबॉर्शन करवाना पड़ सकता है, पर जब तक फाइनल हिस्टोपैथ बिल्कुल कंफर्मेटरी ना आ जाए ना, तो बेटर है कि बस उससे डिस्कस करके रखो कि हाँ ये करवाएंगे और ये सब साइन भी ले लो, बट फाइनल हिस्टोपैथ के बाद ही उसका अबॉर्शन कराओ, फॉर फ्यूचर प्रैक्टिस पर्पस ऑल्सो।
Because this is their decision anyway. Okay. After discussing about termination, then you will decide here BCS is not indicated. You will do mastectomy with axillary staging. According to your SLNB, you will do completion axillary lymph node dissection. Then you will follow it up. You will start, if they need chemotherapy, then you will start after they get into second trimester. RT is to be given only in the postpartum. Adjuvant endocrine therapy also is given in postpartum. Then coming to second trimester, there's nothing much of a change here. You can give pre-op therapy also by chemotherapy. You can do BCS also in them. Then you can follow it up with chemotherapy and adjuvant RT and endocrine in postpartum. So later in pregnancy, definitely you can resort to any form of treatment, because after they deliver, you can give them RT and endocrine therapy as well. Then coming to carcinoma in situ, inflammatory breast cancer, So this is a rapid onset where duration of symptoms should be less within 6 months, where there'll be erythema occupying more than 1/3 of the breast, the fluidy orange appearance, and here there'll be tumor emboli in the dermal lymphatics. There are two scenarios. The tumor emboli may not be there in the lymphatics, but the clinical picture matches your inflammatory breast cancer, then it is inflammatory breast cancer. If there is no clinical picture, but there is only dermal lymphatics infiltrated by tumor emboli, then it is not inflammatory breast cancer. So they come under T4D. Then you will here take clinical history. You will get their complete blood panel, their ERPR and HER2 status, then genetic counseling. Then you will get imaging, that is bilateral mammography. You will do metastatic workup by either CT or PET. Then MRI is optional. Then how do you treat them? You will start them with neoadjuvant therapy, which is must and should. Then you will see for their response. After there is response to your neoadjuvant therapy, then you will do total mastectomy with axillary clearance with RT to chest wall and regional node irradiation, inclusion of any portion of undissected axilla at risk or delayed reconstruction. So you will add radiation to chest wall and RN9. Then you complete the perioperative chemotherapy in case you have not completed them in the neoadjuvant setting, and you will add a targeted therapy depending on their molecular classification. If there is no response, then you will not put scalpel. You will add some other form of systemic therapy, or you will change the line. Then patients may be candidates for multiple lines of systemic therapy to palliate. Then the intent will become palliation.
तुम लोग के यहाँ भी बेबी है क्या? तुम लोग के यहाँ भी बेबी है?
This is my husband's niece. So they've come home today. So let's go into breast imaging. Here in mammography, okay, what are the things that they have asked in mammography is BIRATS categorization, contrast enhanced mammography, molecular breast imaging. Then there's a question on mammography density, that is the ACR grading, ABCD. Diagnostic mammography, there is two standard view, that is craniocaudal and mediolateral. Then depending on the location of the tumor or you want more clarity, there are different views and magnification spot compression that you will can add to the normal mammography. So the intent of mammography can be screening or diagnostic. Then American College of Radiology has given ABCD depending on the proportion of fat in the glandular component. Less than 25% glandular component, and if it starts increasing by percentage, it becomes more dense breast. So the C and D are usually dense breast, where adjunct radiological imaging like tomosynthesis, contrast enhanced mammography has added advantage in detecting your missed masses. Then you will categorize depending on the suspicion of malignancy as BIRADS category 0, 1, 2, 3, 4, 5, 6. There was a call. I put them all in one. Okay. This will, there are features that will tell you whether it is an inconclusive mammography, whether it is negative or it is probably benign. It's benign probably, or index of suspicion increases, and what is the percentage or likelihood of malignancy, and what is the probable thing that you'll have to do. There are two things that you'll have to know. One, your clinical suspicion should be added to your BIRADS category to make clinical decision. So the radiologist will give whether it is an incomplete study, maybe it was too dense that you could not see anything, or the film was not very clear. In these, they will want additional supplement studies. And here, in case there is high index of suspicion that whatever you are feeling is malignancy, then you can resort to any of these adjunct methods of pickup rates or MRI also. Category 1, she's very sure that she will report it as negative and the likelihood of cancer is 0. But in category 1 reported patient, clinically you will feel it is suspicious. Recent onset nipple retraction, there is mass, there is, you feel it is hard enough, then you will have to subject this patient for biopsy, and this is NCCN recommendation. Then category 2 is probably benign, where again there is no increased likelihood of cancer. In probably benign category 3, there is a risk that is as less than 2% of developing into malignancy. Then this is what they say, category 3 should not be assigned to a palpable lump, like say it is suspicious clinically, then they would add an adjunct reporting telling that better subject this patient to biopsy. So your clinical suspicion will take over the radiological reporting in wanting a biopsy. In 4, it is 2 to 95%. Category 5 is more than 95%. 6 is a proven malignancy. So this is the digital breast tomosynthesis. Here the detector is static. The X-ray machine keeps rotating from 15 degrees to 60 degrees. It will take multiple sizes and different angles so as to 3D reconstruct the parenchyma and the mass, so that there won't be any overlapping. You can clearly delineate. There'll be high resolution in obtaining images, and there is better detection rate, decrease in callbacks. This is used both in screening as well as diagnostic imaging. Here they say the radiation dose is twice as your screen film or digital mammography, but it is less than the safer limit of dose radiation exposure. So it is still recommended. here you will decrease the false negative or false positive radiation. But addition of digital tomosynthesis to your digital mammography does not alter your re-excision rates. That's what they say. This computer aided detection not of much importance. In ultrasound, we have to read about elastography also. So elastography is on the basis that this mass has a different consistency and compressibility compared to the normal parenchyma surrounding. So when you compress your probe and after the waveforms are generated because of difference in their compressibility, they give a different waveform feedback. This I've made notes that I'll share about elastography and this digital tomosynthesis. Okay, oncoplasty. Construction. Okay, we'll go to neoadjuvant, then come to oncoplasty. I have different slides for neoadjuvant therapy. It can be chemo or neoadjuvant endocrine therapy, neoadjuvant targeted therapy. What are the advantage of neoadjuvant therapy is? Okay. So, when the tumor is in situ itself, you will know the response to chemotherapy. One. Second, it downstages. It will address all your micrometastasis. It will help in conversion of a mastectomy to breast conservation surgery. So, the most important thing why we resort to neoadjuvant therapy is pathological responses directly related to your overall survival by many trials. So, the regimens when we go to NCCN, we'll discuss all that. So multi-gene panels or recurrence models. So when you want to de-escalate, when you want to avoid chemotherapy in a very good group like HER2 ERPR positive, HER2 negative risk patients with either node negative or 1 to 3 node positive, you will you will subject them to multi-gene analysis to get some scores, so that depending on their risk stratification, you can resort not to give chemotherapy. So there are some multi-gene panel assays that are given. That is Oncotype DX. It's a 21 gene RT-PCR molecular assay that will give you the risk of recurrence for 10 years. So it's on the it's a predictive and prognostic model. Here, patient should be lymph node negative, hormone positive, HER2 negative, T1, T2. So in premenopausal, you will have a 3 risk stratification depending on their score: less than 11, 11 to 25, and more than 25. In more than 25 patients, you have to give adjuvant chemo. In intermediate risk, you can really have a dialogue with the patient and you can consider to omit, but it is recommended to give. In less than 11, you can omit giving chemotherapy. In postmenopausal, there is only 2 groups, less than 25 and more than 25. Less than 25, you can omit. More than 25, you will have to give. In MAMA print, it's a 70 gene analysis where node positive patients are also taken into consideration, and the order of recurrences, the score is between 0 to 100. Breast cancer index, it predicts the risk of recurrence to 5 to 10 years. It's a prognostic and a predictive model. Here, you can predict extending your hormonal therapy depending on your breast cancer index score. Prosigna and endopredict. Endopredict is a 12 gene model with a risk of recurrence score. This is done for 0 to 3 lymph node positive patient, HER2 node negative, 1 to 2 T1 T2 with hormone positive.
Oncotype DX is also for node positive also, and it's also valid. So
Now it is there for 1 to 3 lymph node positive. So when we go through that NCCN, we can see that tables actually. Here, what are all the questions that are there? Depending on your luminal types, we will go through the treatment model where we will see the chemo targeted therapy, role of post mastectomy radiation, and hormonal therapy. We'll go to that one only, no? Just a second. We'll go through NCCN only. There'll be a lot of things we can go through: endocrine therapy, endocrine resistance, and all that. Okay. Okay, in radiation, they've asked about post-mastectomy radiation and ABPI. So here you have to write about the techniques here. External beam can be used, or brachytherapy, especially in intraoperative radiotherapy. So coming to normal post-mastectomy radiation, here the target includes ipsilateral chest wall and the entire mastectomy scar and scar site. So this is the field of radiation. Then whether to include regional node irradiation or not, there are specific indications for that. So what are the indications for post mastectomy radiation? The classical indications are when there are N2, pathological N2, that is more than or equal to 4 nodes, positive margins, tumor more than 5 centimeter. So there are two things: T size more than 5 centimeter, more than or equal to 4 positive nodes, and positive margins. Between in 1 to 3 positive nodes in T3 disease, ENE, lymphovascular invasion, close margins, there are controversy. Here, NCCN says you can consider, but it is not a mandatory thing to do. So here I have marked, just a second. Sorry, I have to go back and forth. Adjuvant, systemic. Okay. So after mastectomy, see, these are the 4 scenarios. If the axilla is negative for nodes, if the tumor is less than 5 centimeter, if the margins here, see, it's not that margin negative on ink, it is margin more than or equal to 1 mm. Absolutely, you can avoid RT. Then comes the other scenarios where they tell you can consider RT or you can strongly consider RT. So, what are those scenarios? More than 4 positive axillary node, definitely you are giving. Margin positivity, re-excision should be done. It's preferred over going ahead with RT. What are the in-between scenarios? Like 1 to 3 positive nodes, more than 5 centimeter tumor, margin less than negative but less than 1 mm. In these, it is told to strongly consider RT. So while writing indications, you can write clear indications and some controversies in post mastectomy RT. Regional node irradiation. Absolute is under dissection. You have not addressed the axilla where you have not harvested 10 nodes, no? Axilla?
Yes.
Okay. You have not completely dissected the axilla, or you have obtained less than required number for pathological staging, then you have to give regional node irradiation. What are the other things? That means those sites which cannot be surgically accessed, like internal mammary, where the positivity is there on imaging, or there can be occult metastasis like in medial and central quadrant tumors in them, and when there is N2 N3 disease in the axilla, then you will resort to give supraclavicular irradiation. Internal mammary, if the location of the tumor is central or medial and image positive nodes, in then you will resort to regional irradiation where supra, infra, clavicular, axillary and internal mammary is irradiated. So what are the things, when do you sequence your RT? After completing your chemotherapy, you can give your radiation. The only regimen that can be combined with RT is CMF. You can comfortably combine your targeted therapy, that is HER2, and endocrine therapy with RT. None of your CDK4 inhibitors irradiation. They wanted to de-escalate in low risk group, finish off the radiation instead of giving it for 5 weeks. They wanted to finish in 1 or 2 weeks.
ABPI का ना एक वीडियो आई थिंक पढ़ा होगा, 2 वीडियोस हैं ऐसे, उस टाइम मेरे भाई ने मुझे पढ़ाए थे, तो अगर देखना हो तो देख लेना। उसमें उसने कॉन्सेप्ट भी बताया कि ABPI इसमें क्यों चूज़ करते हैं, और ब्रेस्ट में और प्रोस्टेट में 2 ही ऑर्गन है उसमें देते हैं, और उसके साथ साथ उसने ABPI के ट्रायल्स भी बताए हैं।
Okay, because I've not included trials in this. Okay, so low risk early stage breast cancer, and those patients who were the ones whom you can select, they should not have BRCA1 or 2 mutation. They should be more than 50 years. By tumor criteria, they should have less than 2 centimeter, invasive ductal with grade 1 or 2, no LVSI, no extensive intraductal component, pure DCIS. If it is existing, it should be less than 2.5 centimeter, ER positive, surgical margin more or equal to 2 mm, unifocal, no lymph nodes, no BRCA mutation, no neoadjuvant therapy, and lymph node status can be proven negative by lymph node biopsy. So these are the suitable factors whom you can resort to give external beam radiation or balloon or interstitial. So the fractions here are, it can be given 1 week, 2 week or 3 week, 30, 34 and 40. If it is 1 week 30, 2 weeks 34, 3 weeks 40 by EBRT. If it is brachy, we use balloon or interstitial method where 30 gray is given in 10 fractions. Question on male breast cancer is given here. Male, they have similar prognosis, similar treatment to their female counterparts. The lacunae in male breast is only few trials have included male breast cancer for evidence-based medicine. Otherwise, what and all you will have to look. NCCN here. Okay, few males are included in breast cancer trial, and therefore recommendations here are generally extrapolated from the studies that are done on females. Although there are some biological and clinical differences between breast cancer in male and female, the management overall remains the same. What are the special consideration that NCCN give? All male breast cancers have to be subjected to genetic testing. Number 1. Breast surgery, BCS also can be done in mastectomy. However, the data is insufficient to say which is safe, but you can resort to do BCS or mastectomy. There is role of SLNB like females. RT indications after breast surgery is same like females. Molecular assay, 21 gene assay recurrence score provides prognostic information in male breast cancer. Preoperative and adjuvant systemic therapy. In case of chemotherapy and targeted, it is same like female breast cancer. What is the difference in adjuvant endocrine therapy is tamoxifen is safely given But if tamoxifen is contraindicated, like if the patient is deep vein thrombosis patient, in such cases, you will have to give them along with an ovarian suppression, that is GnRH analogs. Otherwise, pure giving aromatase inhibitors, they can be counterproductive, like increasing estradiol from unsuppressed sources, thus increasing progression or recurrence. So tamoxifen can be given alone for 5 to 10 years, but if you want to give anything other than tamoxifen for whatever other reason, then you'll have to give along with GnRH analog. Then follow up after treatment for early stage, there is limited data. Okay, here for screening there is limited data, so we really don't subject them for screening. Then here, before starting your adjuvant therapy endocrine, you have to have baseline bone density and assessed every 2 years. So what you don't give in male breast cancer because of lack of evidences: CDK4/6 inhibitors, anastrozole alone, fulvestrant alone, mTOR inhibitors or PIK3 inhibitors. Otherwise, you can give any all the other things are similar as female. So no CDK4, no monotherapy by aromatase inhibitors, no fulvestrant alone, mTOR or PIK3. So when I went to fulvestrant, I might as well thought I'll just put a note here. They've asked for 3 marker. Fulvestrant is a estrogen receptor down regulator, which has got only an antagonistic action, no agonistic action, and it is given intramuscular. The indication here are: it is given in high risk, hormone positive, HER2 negative, advanced or metastatic breast cancer, which are endocrine resistant, and in recurrent setting. It is added either with CDK4 inhibitor or PIK3 inhibitors. Contraindications, they are not given in pregnancy and lactation. The adverse effects are: they cause neutropenia, thrombocytopenia, anemia. So hematological adverse effects. Cardiac, they have increased incidence of ischemic events. They are hematogenic and they cause constipation, GI related complication. Coming to adjuvant endocrine therapy, in endocrine they've asked role of neoadjuvant endocrine therapy and modes of endocrine resistance. So the general principles are: ER testing you will do 1 to 100 is taken as positive, 1 to 10% is taken weak, and the evidence is supporting their utility in preventing risk or prolonging or survival benefit is depending. It depends on the other factors that will dictate the biological behavior. In ER negative, PR positive may be considered for endocrine therapy, but the data in this group is limited. This same overall interpretation principle apply, but PR should be interpreted as either positive, that is 1% to 100% of cells having nuclear staining. It is negative if it is less than 1% or 0% of cells. Then coming to that's what low ER expressors are less likely to benefit, but you will definitely consider giving endocrine therapy to them. Ovarian suppression. Here, especially in premenopausal women, endocrine sensitive patients who have high risk of recurrence, which is dictated by their young age, high grade tumor, lymph nodal involvement, you will add ovarian suppression to your endocrine therapy as dictated by soft and text trial, that said, which decreases the recurrence rate and there is survival advantage adding your adjuvant therapy with ovarian suppression, and aromatase inhibitors did better than tamoxifen. Ovarian function assessment. So whenever your menopausal status has to be determined by your ovarian function assays. Here, when a patient is premenopausal by age, you have not ascertained her menopause status, you will have to keep assessing the ovarian function by FSH and LH. in these scenarios. So definition of menopause is given by age. All more than 60 years are taken menopausal, and those who are on chemotherapy or some form of endocrine therapy, then they should be deemed menopause by their FSH and LH assay. So this is the definition. Menopause is a permanent cessation of menses and indicates profound or permanent decrease in ovarian estrogen synthesis. So more than or equal to 12 months of amenorrhea. In patients, this is the thing. So those who are more than or equal to 60 years, those who have had bilateral oophorectomy. For those less than 60 years, if there is amenorrhea more than 12 months in absence of chemo or endocrine therapy or ovarian suppression, who have estradiol FSH in the postmenopausal range, then they are menopause. If they are less than 60 years, they are on chemotherapy, their FSH and estradiol has to be in the range of postmenopausal and should be ascertained on serial assessments. Less than 60 years on tamoxifen, yet you will do FSH and estradiol to assess their postmenopausal state. Postmenopausal status cannot be determined in those receiving ovarian function suppression. That is why in these GnRH analogs, when the patient is receiving, they are subjected to serial assessment of these FSH and estradiol, especially prior their once prior start for their menopausal status. So this is what they're telling. Monitor their estradiol and follicular stimulating levels. If under 60 on endocrine chemotherapy, then it has to be done. Okay, somewhere they've written it has to be done before starting your GnRH, and okay, prior to next dose of GnRH agonist, particularly in women under 45 years. Frequency of testing of estradiol and FSH should be individualized. So you have to serially assess their ovarian function. Then aromatase inhibitors can stimulate ovarian function. If vaginal bleeding occurs while on AI, one should contact a physician immediately. So what are the ovarian function suppression methods? It can be medical, that is GnRH agonist, radiation therapy, or surgical bilateral oophorectomy. So when to initiate ovarian function suppression? With the start of chemotherapy, whether neoadjuvant or adjuvant. If chemotherapy is not planned, OFS should be started alone for at least first 2 cycles. Then you can start chemo, or concurrently you can start them with tamoxifen until estradiol level is postmenopausal, at which time aromatase inhibitors can be considered. So you have to bridge it with tamoxifen, then start aromatase till the GnRH works to get the ovarian function to postmenopausal level. So it can be given concurrently with RT or with completion. So only thing is you cannot start GnRH with AI. You have to bridge it with tamoxifen and then give aromatase once ovarian suppression is confirmed by lab. So 5 years optimal according to the soft and text trial. There is no efficacy or safety data to support prolonged usage. It is encouraged to complete at least minimum 2 years of ovarian function suppression. So this is translated into 8-year disease-free survival in 85% of them with ovarian suppression and tamoxifen versus 80% in tamoxifen alone. Premenopausal patient wishing to continue adjuvant endocrine therapy after OFSF stopped should use tamoxifen. Then CDK4 inhibitors plus or minus with adjuvant, the same thing that we discussed. Rakesh discussed about this Natalie trial and Monarch trial. So that is what. Okay. So you can consider giving adjuvant abemaciclib according to Monarchy trial in eligible, that is high risk patients who are ER/PR positive, HER2 negative, high risk, that is nodal disease more than 5 centimeter, T2. So where is the risk
More
category?
than
Okay, those high
more than 4 lymph nodes and 1 to 3
more
lymph
than or
nodes.
equal to 4 positive lymph nodes confirmed pre-operative. 1 to 3 with grade 3 and tumor size more than 5 centimeter, that is T2 disease.
This is
And
high risk
here 2
RT
years
वाला
of
risky है आई
adjuvant
थिंक. RT के लिए जो
similar.
इंडिकेशंस थे वही है अप्रोक्स.
Yeah, more than or equal to 4 nodes, 1 to 3 nodes with other things like grade 3, tumor size more than 5 centimeter, you will give 2 years of adjuvant abemaciclib. And here
Venous
also
thromboly
Ki67.
embolism risk रहता है abemaciclib और tamoxifen में.
So then you can give 3 years of ribociclib with aromatase inhibitors if there is thromboembolism risk.
Okay.
Okay. And this is what sandwiching. You can start with for postmenopausal, you can give only aromatase inhibitors for 5 years, or you can give 2 to 3 years of aromatase inhibitors and rest you can give them tamoxifen, or you can start with 2 to 3 years of tamoxifen and complete aromatase inhibitors for 5 years. So these are the sequence you can sandwich and you can give. You can consider mono or you can give one after the other. So this was the gene analysis. So gene expression assay in node negative and node positive, that is PN1 1 to 3 nodes, they are both predictive and prognostic because here oncotype DX21 gene has been asked as a question. So it is done in post and premenopausal. The cutoffs are different, and 70 gene is MAMA print. So apart from oncotype DX, all the others have only prognostic. Predictive, one other thing is BCI. Oncotype DX21 gene and BCI have predictive abilities, rest everything has only prognostic. 50 gene is prosigna, 12 gene is endopredict. Here it is for node positive disease. So what are the cutoffs? In postmenopausal, it is only 2 categories, less than 26. So patients with, T1B/C to T2, N0, hormone positive, HER2 negative. According to these Taylor-X study, they said there is no benefit of addition of chemotherapy to endocrine, so you can safely omit chemotherapy and resort to give only endocrine therapy in them. So for scores between 0 to 10, it is Taylor-X. For scores less than 26, it is Ponder-X trial. So in more than or equal
नोड
to
पॉजिटिव
26
वाले का जो था ना वो RX पॉन्डर ट्रायल था, और जो नोड नेगेटिव वालों का ट्रायल था दैट इज टेलर एक्स ट्रायल. तो नोड पॉजिटिव में भी हम ऑन्कोटाइप DX कर सकते हैं, ये RX पॉन्डर ने बोला, और टेलर एक्स ने बोला कि PN0 में, और ये दोनों ही RCTs हैं, इसलिए दोनों लेवल 1 एविडेंस है फॉर ऑन्कोटाइप DX. सो इसीलिए ये कैटेगरी 1 रिकमेंडेशन है.
Okay, so I think then for N0 there are risk scoring of 0 to 11, 11 to 25 and more than 25, is it? Even in postmenopausal?
या
No.
टेलर एक्स का जो स्कोरिंग है दैट इज फॉर प्रीमेनोपॉजल पोस्टमेनोपॉजल, वो दोनों ही N0 का है, और जो नोट पॉजिटिव का स्कोरिंग है वो RS पॉन्डर का है.
So in this assay is given Here for postmenopausal with N0 or with node positive, they have given only single cutoff, but in the trial, I think they have subdivided and taken.
हाँ but we have to remember this values only because ये NCCN ने इसको ही फाइनलाइज किया है ना, वो वाली वैल्यूज डिफरेंट है जो ट्रायल में है.
So in postmenopausal there is only single cutoff. Yeah, whether it is node positive or negative, there is single cutoff. In premenopausal, in node negative there is 3 categories. In node positive there is 2 categories. So in all N0s, you have to quote Taylor X and Rx ponder in N plus. So there's another thing to here. 11 to 25 score. Ovarian suppression has to be added and chemo can be avoided by softened text. Then 70 gene mamma print, there is high and low. Here it is for both N0 and N1. They've just said high and low. 50 gene prosigna is again even for N0 and N plus. So here it is 0 to 100, where low, again low, intermediate and high. For node negative, there are 3 categories. For node positive, there are 2.
इससे पहले
12 gene endopredict
इससे पहले वाला जो NCCN का पेज है ना, पहले उसमें देख लो कि कैटेगरी 1 कौन कौन सा है, सिर्फ वही पढ़ लेंगे. इसके जस्ट पहले एक स्लाइड है जिसमें उसने बताया कि कौन कौन से कैटेगरी 1 है. तो इसमें तुम देखो तो ऑन्कोटाइप DX एंड मैमा प्रिंट ओनली कैटेगरी 1 है. ठीक है, तो सिर्फ यही लिख के काम चलेगा, बाकी सब में और सिर्फ ये
नोड पॉजिटिव और 2A.
नोड पॉजिटिव 2A है, बट अभी
प्रीमेनोपॉजल बिकॉज़ दे आर हाई रिस्क.
फॉर पोस्टमेनोपॉज
young patients no in premenopausal with node positive, instead of seeing scores to avoid chemo, better might as well give chemo because they are young and high risk group, no?
Yeah,
so that is why it is category 2A cat. Otherwise what we have to remember is 21 gene oncotype DX and 70 gene
mamma print. बाकी ये सब नाम लिख देना, बट उतना याद नहीं रहेगा. पर ऑन्कोटाइप DX को अच्छे से मेंशन करना बिकॉज वो प्रिडिक्टिव भी है, प्रोग्नोस्टिक भी है, और N1 और N प्लस सब दोनों में कैटेगरी 1 भी है. तो एटलीस्ट कुछ तो नंबर मिलेगा इफ़ यू कैन नॉट रिमेंबर एवरीथिंग.
Correct. Okay. BCI is both prognostic and predictive because it will dictate extension of your endocrine therapy. In high risk, for patients with T1, hormone positive, HER2 negative with N0, BCI high scores rates demonstrate significant late recurrences. So the secondary analysis of MA.17 atom trial, ideal trials, said that for hormone positive T1, T3, N0 or N plus with high BCI, there is significant improvement in DFS in extended therapy endocrine compared to control arm.
एटलस भी था क्या? यही तीनों था. Atom,
I think
ideal,
for BCI they have not quoted Atlas. Only these 3 trials. Here they quoted only these 3.
तो ठीक है, 10 years देना है ना इनके हिसाब से.
10 years. So high BCI, extended endocrine therapy. Two centimeter. Okay, they have divided early stage into node positive or more than 2 centimeter, or low risk group, that is less than 2 centimeter, node negative. Here, whom do you give? Okay, here anyway you have to do upfront surgery only, no? In less than 2 centimeter, it is upfront surgery.
In our setting,
in
तो we more than 1 centimeter HER2 positive और TNBC we are giving chemo. बट इसने ऐसे बोला है कि 1 to 2 में भी सर्जरी कर दो एंड एडजुवेंट कीमो दो, और लेस देन 1 सेंटीमीटर में तो कीमो का रोल नहीं है. Until and unless
TNBC 2 centimeters cut off and HER2 1 centimeter, no? Or 0.5.
for chemo और
start with
for
neoadjuvant.
ऐसा एनसीसीएन ने प्रॉपर मेंशन नहीं किया है कि कितना सेंटीमीटर है. फिर ही बोलता है कि मोर देन 2 सेंटीमीटर एडजुवेंट न्यू एडजुवेंट कीमोथेरेपी कैन बी कंसीडर, और मोर देन और इक्वल टू 1 ऐसे करके लिखा है. आई डोंट नो, इतना ऐसा एग्जैक्ट सेंटीमीटर मेजर नहीं किया है उसने, बट हम लोग ऐसे देते हैं.
Less than 2 centimeter node negative, you can do upfront surgery. Then if it is less than 1 centimeter, so subcentimetric, you can have an option of observation. Beyond 1 centimeter, you will give chemotherapy because it is TNBC. For more than 2 centimeter and lymph node positive, chemo immuno trial with keynote 522. Here you consider to give anthracycline followed by taxane regimen. Carboplatin addition has got benefits in PCR and overall survival also. Docetaxel as per Neopact, okay, can consider.
पर इसमें हमको उसने बोला था, जो हमारा मेडिकल ऑन्कोलॉजिस्ट आया था, आपको CPS स्कोर या ट्यूमर बर्डन स्कोर जरूर देखना है बिफोर गिविंग टू पेम्ब्रोलिजुमैब. CPS स्कोर या ट्यूमर बर्डन स्कोर जरूर देखना है. इफ वो मोर देन 10 है, then only you will go for this ACTC plus pembrolizumab. ठीक है.
Okay. Addition of immuno depends on your CPS score more than 10.
मतलब कीनोट 522 तुम तभी फॉलो करोगे जब CPS मोर देन 10 है. अदरवाइज तुम ये दूसरा वाला जो रेजिमेन है नियोपैक्ट वाला तो दोगे. बिना CPS स्कोर के इसका ये वाला कीनोट फॉलो नहीं करना है, ऐसा मेडिकल ऑन्कोलॉजिस्ट ने बोला था. पर मैंने कीनोट 522 पढ़ा नहीं है.
Two things. Neopact is saying those patients who are not eligible for anthracyclines, for them you give carbodoxy and pembro. And for pembrolizumab, CPS 10 is an indication. It's a biomarker to tell whether to give immunotherapy.
Yeah. ये मेडिकल ऑन्कोलॉजिस्ट ने बोला था मुझे.
Okay. Then you do surgery. Then you will assess what to give in your adjuvant. If you're given your adjuvant pembro, you will give adjuvant pembro. If there is residual disease, then you will give capecitabine according to CREATE-X trial, pembrolizumab according to keynote 522. If it is BRCA mutated according to Olympia trial, you will give olaparib. So, and now there is role for if this TNBC is because of low HER2, that is 1 plus or 2 plus negative fish, then you can give deruxtecan, TDX.
तो इसमें तुमको ये ध्यान रखना है कि सेम रेजिमेन है, दैट इज AC plus TC plus pembrolizumab, बट ये 355 है फॉर एडवांस कैंसर एंड 522 है फॉर अर्ली ब्रेस्ट कैंसर. और ऐसा इसमें नहीं है, ऐसा बहुत सारों में है कि रेजिमेन सेम है पर मेटास्टेटिक सेटिंग में वो ट्रायल अलग है, और एडजुवेंट सेटिंग ये अर्ली ब्रेस्ट कैंसर में ट्रायल अलग है. तो थोड़ा सा ही उससे काम हो जाएगा. 522 इज फॉर अर्ली एंड 355 फॉर एडवांस्ड. तो अगर ज़्यादा अगर सोचना में आएगा तो ये देखो, नॉर्मली सब जो चीज़ें हैं वो पहले मेटास्टेटिक सेटिंग के लिए बनी है. ठीक है. तो जो छोटा नंबर है 355 इज स्मॉलर देन एडवांस वाला ना 522, इफ़ यू आर कंफ्यूजिंग कि इसमें कौन सा है, तो हमेशा जो एडवांस सेटिंग वाले हैं ना वो ग्रेटर नंबर होगा देन अर्ली। जैसे कि तुम अभी मेलानोमा पढ़ रही थी तो उसमें की नोट 006, तो की नोट 006 वॉज द फर्स्ट ट्रायल जिसमें निवोलुमैब और पेम्ब्रोलिजुमैब आए थे एक्शन में या चेकमेट। तो जो अर्ली वाले नंबर हो गए ना, स्मॉल नंबर, वो हमेशा एडवांस के लिए है, मेटास्टैटिक सेटिंग के लिए।
ओके,
ठीक है, तो ये ऐसा लॉजिकल है।
answer 355. Okay. So in early, what you'll have to remember is size cutoff is 2 centimeter, node positive or node negative. Then in more than 2 centimeter, node positive early stage, there is role for chemo immuno, told by keynote 522. Then you will see biomarker CPS, whether it is 10. In advanced, they have mentioned CPS more than 10, but in early they have not. So we have to check this 522.
पर मैंने उन मैडम से पूछा था स्पेशली, मैडम तब मैम CPS 10 देखना ज़रूरी है, तो उन्होंने कहा हाँ बिना उसके नहीं देंगे। वो एक सर आए थे और जिन्होंने इस पे ही क्लास ली थी हमारे यहाँ। तो जो मैं एक बिहार कॉन्क्लेव में गई थी ना, तो वो दिल्ली के कोई सर थे, एम्स के या कहीं के, तो उन्होंने बोला कि बिना इसके CPS स्कोर के यू शुड नॉट गिव पेम्ब्रोलिजुमैब।
एडवांस TNBC में एक बार दिखाना ना। एडवांस TNBC में अगर PD-L1 नेगेटिव है,
then no pembrolizumab.
No, that is okay, but they go through germline testing only if PD-L1 is negative. ऐसा है क्या? PD-L1 positive?
No.
Chemo plus chemo in advanced.
No, all TNBC you have to do germline testing. No, this I think they are following it up with this same method. It should be done for both.
ये तो ट्रीटमेंट गाइडलाइन के लिए ऐसे बोल रहे हैं। लेस देन 50 इयर्स भी TNBC है तो सबको ही करना ही है BRCA टेस्टिंग ना।
No, because this one it is indicated, no, the olaparib.
नहीं, एडवांस TNBC में सर्जरी कहाँ पे आया? That's what I'm thinking right now. अभी कहाँ पर एडवांस TNBC में कीमो प्लस पेम्ब्रो एज NACT और कीमो प्लस, मतलब वेयर इज द सर्जरी?
ये मेटास्टैटिक है, इसको एडवांस में ये मेटास्टैटिक सेटिंग है।
अच्छा, ठीक। Okay.
Then this will not be just early, no, this will be even locally advanced.
हाँ, मतलब that is why ना, more than 2 centimeter or node positive, so technically you would think early is T1, T2 only ना, तो T3
but even in locally advanced more than 2 centimeter, this thing only is applied.
हाँ, we usually give total NACT ना।
Correct. And I'm not sure about neoadjuvant immuno, but definitely chemo, yeah.
हाँ, तो ये more than 2 centimeter node positive will be for all except less than 2 and node negative.
Yeah.
You give total neoadjuvant ACTC plus pembro followed by surgery, patch CR and और रेजिडुअल डिसीज।
और इसी के कारण चांस है कि इस बार TNBC पे क्वेश्चन आएगा बिकॉज ऑफ दिस 522।
Then you will because in both the settings you'll have to give olaparib, so BRCA testing is there in both. Then in metastatic setting, if you're giving olaparib or talazoparib according to Olympiad or EMBRCA trial, then additional role of HER2 low patients. So here you can give
आया है रोल डेस्टिनी ट्रायल,
deruxtecan,
डेस्टिनी 04,
secukinumab, Covican.
इतने सारे तो याद नहीं रहेगा मेरे को। ये डेरुक्सिकैन, ये डेस्टिनी 4 ट्रायल का भी आने की उम्मीद है।
So this is in recurrent after first line.
तो मैंने तो इस टाइम क्लास में बताया था ना कि डेस्टिनी ने HER2 की डेस्टिनी चेंज कर दी है। तो अभी कोई भी पैथोलॉजिस्ट हमको रिपोर्ट देगा तो हमको उससे पूछना है भैया HER2 लो, नेगेटिव और वेरी लो, ये सब हमको बताओ। HER2 पॉजिटिव, HER2 positive तो HER3 plus है.
Ultra low is less than 10%, but positive cells, huh?
Ultra
Positive
low is
staining.
1 plus.
No. In 1 plus only there are two categories, depending on percentage of cells. Less than 10%. Staining is there, but less than 10% is ultra low. Low is 1 plus and 2 plus negative fish. You only thought this. It's there in your slide.
हाँ, ultra low नहीं था उसमें.
So this HER2 low basically comes after there is failure of first line, na?
HER2 low is not if HER2 positive patient है उसमें तो ठीक है. मतलब TNBC में हम HER2 क्यों पढ़ रहे हैं हमको समझ में नहीं आ रहा है.
मैं वही कह रहा ना, ये सेकंड लाइन में आएगा. एडवांस TNBC में you give immuno, chemo and और जर्म लाइन ब्राका के हिसाब से उसमें फेल हुआ पेशेंट या प्रोग्रेस किया, देन यू डू HER2 टेस्ट आल्सो जस्ट टू सी. TNBC में HER2 हो ही चुका होगा ना,
पहले ही हो
जस्ट
चुका
नीड टू
होगा.
सी कि कितना है. हाँ, यू जस्ट नीड टू सी कितना है. 0 है, 1 है, 2 है, दैट इज ऑल दैट यू नीड टू सी.
हाँ, तो 1 और 2 प्लस में हम दे सकते हैं.
or whatever.
और दूसरा चीज
what
ये
the concept
था
was-
इसमें एक और चीज मेरे को भी क्या याद आया था. हाँ कि एक तो हम TNBC से पहले पैथोलॉजी कराते हैं, ठीक है, पर ये बोल रहा था कि बहुत सारे पेशेंट में कीमो देने से उसके बाद भी उसके मार्कर्स चेंज हो जाते हैं. तो जब हम ऑपरेट करते हैं तो हमारा जो हिस्टोपैथ आता है ना उसमें हमें फिर से हिस्टोपैथ करानी चाहिए, वो IHC करानी चाहिए, जो हम अपने रूटीन प्रैक्टिस में तो हम नहीं कराते हैं यहाँ पे. अब तुम लोग क्या कैसे होता है पता नहीं, बट जो ये क्लास पढ़ाया था उसने बोला था कि बहुत सारे मार्कर्स चेंज हो जाते हैं तो हमको फाइनल हिस्टोपैथ में फिर से IHC कराना चाहिए. फर्स्ट जो हमने कराया था उसके हिसाब से ही पूरा ट्रीटमेंट नहीं देना चाहिए, ऐसा वो बोल रहा था.
So this was actually published in last year's Centennial Breast Conference. The addition of this thing in. So in TNBC there was no biomarkers or any targeted therapy. So they started evaluating as which of those were the resistant clones that were not responding. So they were trying to attribute it to all these low HER2. So when they did trials on them, and these two trials came last year. So they had some benefit in TNBC which failed first line, second line. So that is what they've given. After first line or second line, you can choose to give some form of targeted therapy to decrease the progression or increase the response.
ठीक है.
So then coming to hormone positive, so the good variety. Here, as Samrita was telling, node negative according to the evidence is according to Taylor X, and node positive is RX Pondel. Here you can resort to operable patients early, you can resort to surgery upfront. Then your adjuvant omission of chemo is dependent on your oncotype that we studied now, followed by your endocrine therapy. So this is what is given. Then your selection criteria for BRCA wild high risk patients.
Hello?
For CDK4/6 inhibitors.
नहीं है, पर क्लास चल रहा है मेरा. आप अभी तुरंत आ रहे हो क्या?
So monarchy is abemaciclib for 2 years.
ऊपर आ जाएंगे क्या? कि रख दूं लिस्ट में?
Positive, 1 to 3 node positive with grade 3 or more than 5 centimeter. Then in Natali for ribociclib, 3 years in stage 2A. So stage 2A will be T1, N1, node N1 or N2. Okay, T2, N0 also will come in this one. Stage 2A, if N1 or N1 high with high risk, 2B with 3, I am not sure what. I probably will take this as N plus with more than 4 nodes, N0, N plus with 1 to 3 with more than 5 centimeter or grade 3, and especially in BRCA wild, because you can't give olaparib in them. So if BRCA is positive, then according to Olympia trial, give 1 year of olaparib to T2 patients or more than or equal to 4 node positive. Then coming to advanced HER2 positive, here probably it is in metastatic setting. They can present metastatic de novo or they progressed on endocrine therapy. So they progressed or they recurred within 12 months of endocrine therapy. So we have to describe an entity called endocrine resistance, mode of resistance, and therapy for this. This I'll have to study. I don't know the definition. Probably it is progression on endocrine and recurrence within 12 months only. So for them, you will do combination therapy. So with endocrine, you're adding CDK4 inhibitors. You're targeting alternate pathway of acting. So here in advanced setting metastatic, abemaciclib is Monarch 2-3, ribociclib is Mona Lisa, and palbociclib is Paloma 2. Then if they are endocrine sensitive, you will subject them for NGS and see if there are other mutations in order to add PIK3 inhibitors.
If वो काम नहीं कर रहा है तब, if first line है वो जो तुमने
always if it is you can keep it as maintenance till they don't respond or they progress, then only you will switch, no? Then you will reascertain other mutation analysis and you give targets. Alpelisib with endocrine, capivasertib, elkestrant. Then if it is BRCA, then you will give PARP, that is olaparib and talazoparib according to Olympiad or Embraca. Then these are progressing on your already endocrine therapy or they recurred within 12 months. Then there is role for PIK3 inhibitors in mutant cases. So you will add two things. Palbociclib, three things. Palbociclib, fulvestrant with some PIK3, inavolisib. And after first this line, if it is progressing, then there is role for mTOR, fulvestrant. Then you can even try the same therapies like that we used in HER2 low TNBCs like sacituzumab govitecan and deruxtecan in these settings. So this advanced, what we have to know is in metastatic setting whether you have to know with this de novo metastatic or it appeared while on therapy. Then you will continue to give endocrine therapy and add CDK4 inhibitors. Then you will see whether it is progressing or not. In case if it is progressing, you will subject the patient for NGS and find out any targetable mutations like PIK3, PTEN, AKT, ESR1 mutation. And if it is BRCA mutated or wild type, then if it is PIK3 mutation, then alpelisib with endocrine therapy. PIK3, PTEN, AKT, then capivasertib. ESR mutation is elkestrant, okay, elacestrant. Then if it is BRCA, then it is PARP inhibitors. Then for HER2, same like TNBC, if it is less than 2 centimeter, node negative, upfront surgery, depending on whether it is complete response residue. If it is PT1N0, then you will continue the targeted therapy for 12 cycles and complete 1 year of trastuzumab. TCH with docetaxel. Huh? What is T? That is docetaxel only into TCH?
Yeah, docetaxel and Herceptin.
Okay. Dosage
साइक्लोफॉस्फेमाइड होता है ना?
वो तो TCHP में
TCH तो पूछ रही
docetaxel,
है वो.
cyclophosphamide, Herceptin और वो
एक TCH होता है और एक TCHP होता है. तो TCH we have to give in note negative and TCHP we have to give in note positive.
Here they have not used cyclophosphamide, only 2-drug regimen.
But NCC and TCH और TCHP यूज करता है. पढ़ाया था ना मैंने.
For T2N plus dual blockade you will use adjuvant chemo with plus or minus pertuzumab. Especially pertuzumab, if you use a neoadjuvant, then you will give an adjuvant setting in more than 2 centimeters.
TCH is C for carboplatin. Cyclophosphamide नहीं है. You do not use cyclophosphamide and Herceptin together. Both are cardiotoxic.
कुछ C से है भाई, मेरे को याद नहीं था इसलिए बोल रही.
नहीं मैं इन जनरल बता रहा हूँ. साइक्लोफॉस्फेमाइड और हर्सेप्टिन कभी साथ में यूज नहीं करते हैं. तुम देखोगे ना कभी हर्सेप्टिन
तो P नहीं होता.
यार किसका?
जब भी प्लैटिन यूज करते हैं तो उसका सिंबल तो P होता है ना.
T होता है. हर किसी का अलग है. A, C और T रेजिमेंट में T is for taxane. यहाँ पे TCH के अंदर T is for taxane, C is for carbo. तो ये सब ये मेडिकल वाले ऑन्कोलॉजी वालों का ना कुछ स्टैंडर्ड नहीं है. वो मन मर्जी करते रहते हैं.
ठीक है, लेट मी एक बार चेक कर लेती हूँ फिर भी आंखों से देख.
मैं बता रहा हूँ टैक्सेन एंड प्लैटिन.
जो ये बोल रही है मेरा भी सोच वैसे ही था कि सी आता है तो साइक्लोफॉस्फेमाइड होता है और पी आता है तो प्लैटिनम.
कभी भी कंफ्यूज हो तो जहां तक मुझे याद है एंथ्रासाइक्लिन्स एंड हर्सेप्टिन. हर्सेप्टिन इज आल्सो कार्डियोटॉक्सिक. एंथ्रासाइक्लिन इज आल्सो कार्डियोटॉक्सिक. सो यू डोंट गिव बोथ दीस टुगेदर.
लॉजिकल.
So TCH, okay. Early stage, when you do upfront surgery, depending on a final histopathology report, if it is PT1 less than 2 centimeter node negative, then you will give weekly docetaxel with Herceptin for 12 cycles. Then you will complete trastuzumab. If it is T2 to 5 centimeter or N plus, then you will think to add pertuzumab by affinity trial. Then in advance, where you will have to resort to give neoadjuvant chemo with targeted therapy, dual blockade, then it is TCHP. Neosphere and affinity both use the same regimen, no?
यार
Or
AC.
In affinity, whether they added dual blockade.
क्या बोल रही हो? मैंने देखा सुना नहीं एक्चुअली. TCHP और TCHP.
Affinity versus
नियोस्फीयर.
Neosphere.
नियोस्फीयर में आई थिंक ट्रांसटुजुमैब और परटुजुमैब था ना.
Usually affinity is dual blockade. Okay, both are there. I think. Neosphere is, there are 4 regimens: TH, THP, HP, TP. So all combinations are.
तो सबसे सक्सेसफुल कौन सी रही?
TCHP.
ठीक है.
Okay. Then surgery, then you will see for pathological response. If it is complete, then you will give only targeted by affinity trial. If there is residual disease, you will change to TDM1. Then you will consider to give niratinib in her hormone positive, node positive. So triple positive. नेराटिनिब
तो
for 1 year.
TDM1 देना है कैथरीन ट्रायल के हिसाब से, हर्टुजोमैब, ट्रांसटुजोमैब, पर्टुजोमैब 1 साल के लिए देना है, PCR आएगा, ये एफिनिटी ट्रायल बोल रहा है। और ट्रिपल पॉजिटिव में नेराटिनिब देना है, और पर हर्टुजोमैब भी ये भी देना है और ये भी देना है क्या? दोनों देना है।
After completion, you'll follow it up with 1 year neratinib, I think. I also don't know. Whatever is there, I'm reading. I have to see.
ठीक है।
Okay. Now with metastatic with CNS involvement, if it is there, then you will give THP followed by HP. Then based on
क्लियोपेट्रा ट्रायल,
whether this arrow says yeah, probably, then TDX destiny. So in this metastatic setting, there are so many combinations.
मेरे को लग रहा है जो ये ET लिखा है ना, ये ET लिखा है ना मेरे ख्याल से, नहीं? तो ये HER2 पॉजिटिव के साथ अगर हार्मोन पॉजिटिव भी है तो आई थिंक एंडोक्राइन थेरेपी के साथ हमको देना है इसको।
ओके ओके
ठीक है। और अगर वो सिर्फ HER2 पॉजिटिव है तो एंडोक्राइन थेरेपी नहीं देंगे, सिर्फ HER2 पॉजिटिव की ड्रग्स देंगे।
ओके
ये मुझे समझ में आ रहा है, ऐसा लग रहा है मुझे। तुम लोग क्या बोलते हो बाकी लोग?
मेरा तो सब अभी दिमाग के ऊपर से जा रहा है। मैं डॉन का
ठीक है, तो ये बता दें, मेरे को जो लग रहा है कि ET इसलिए लिखा है कि जब वो हार्मोनल पॉजिटिव होगा, ट्रिपल पॉजिटिव होगा, तो हमको इस रेजिमेन के साथ एंडोक्राइन थेरेपी देना है।
जस्ट होल्ड ऑन,
बाकी का
कल पढ़े।
ज्यादा नहीं हो गया?
ठीक है, कल भी पढ़ सकते हैं। अबे कल फिर से रिपीट करना पड़ेगा, कोई सेंस नहीं है। कल पढ़ते हैं ये HER2 पॉजिटिव।
Tomorrow we will discuss
पहले tomorrow we will start from this chart only, पहले फिर आगे का फिर जो तुम्हारा बचा कुछ है वो पढ़ेंगे।
Oncoplasty, endocrine resistance will study.
कल के लिए तो बहुत टॉपिक बच गए हैं।
We'll do it there.
चल, वही मैं सोच रही थी कि तुम ब्रेस्ट को कैसे 1 दिन में कंप्लीट करोगी, मेरे को 5 दिन में भी नहीं हुआ था।